Hello, everyone. Sorry for the delay. We were having technical difficulties on the back end, but thank you for staying with us. My name is Damian Cabrera, and I'm the program manager for the treatment division at NMAC. And welcome to the Staying Healthy and Summer Body recommendations for preventing monkeypox. If you didn't know this webinar is brought to you by NMAC's Game of Color Fellowship. That's a program where we provide the tools for advocates to leverage their work. And in today's webinar, we are going to be talking about Mpox, but we are also going to be approaching it as a syndemic approach, as we can enjoy a fun, sexy, healthy sex life during the summer and beyond. And with us, we have Dimitri Daskalakis, White House National Mpox Response Deputy Coordinator, and as community representatives and part of the Game of Color Fellowship, we have with us Joe Anderson Jr. from Texas Health Action Kind Clinic. Joe is a marketing and special events manager. Joe is also a storyteller and has dedicated his life to amplifying other people's stories and creating safe spaces for the Black queer community. And we are also joined by Alan Acevedo, who's the HIV planning group of San Diego. And Alan has had multiple positions as peer, one of them being a peer-based HIV for nonprofits, and he has headed committees, and task forces for HIV planning groups and other works. Alan is also a local reporter in San Diego for the only regional LGBTQ publication, and Alan writes stories about national awareness days with the intersection of co-occurring epidemics such as substance use and other STIs, which is perfect for today's syndemic approach that we'll be covering. But before we jump to our panelists, actually, we're going to start with Dimitri, who will be sharing with us some data, and then we are going to have a community conversation with Alan and Joe. But before that, I would like for everyone to make sure that you stay healthy and ready for the summer, and to get more information about HIV, stigma, treatment, prevention, everything about HIV, make sure that you visit the Let's Stop HIV Together website with Chip, who is the Director of Communications, and in the background of this conversation is going to put the link on the chat. And also, if you want to get an HIV self-test free and at your door, make sure that you check out the Take Me Home site. You can fill a super quick questionnaire, and then you get it to your home in just a couple of days. And now I am going to pass it over to Dimitri. Welcome, Dimitri.
Great. Yeah. Can you hear me okay?
Yes, we can hear you okay.
Okay. Thank you. So thanks everyone for your patience while we were sorting through some technical difficulties. I'm going to get through some slides so we can move on to the panel. So first, I just want to give you a retrospective of where we've been with Mpox. And so the first diagnosis of Mpox happened in the United States in May. And this slide just reminds us of what it was like in the early days of Mpox. We didn't have enough vaccines. The name Mpox did not exist yet. The virus was called by another name that is racist and really was damaging to the community. We had trouble with access to the investigational drugs that treat Mpox, and we didn't have adequate Mpox testing. Through a lot of work really driven by the community and supported by the White House and the agencies across government, really listening to the community in terms of what the needs were, a lot of things changed. So vaccine supply increased, new ways of administering that vaccine were approved so that we had enough vaccine to do the job. We increased the amount of testing that was happening in the United States. We increased access to the investigational drug used to treat Mpox, or we think that treats Mpox. And we also worked to bring Mpox vaccinations closer to people through various efforts that happened to bring vaccines to events and other places where folks could benefit could get them. Part of this was also learning from the lessons of HIV and making sure that we really focused on sex positive messaging. And that messaging was really designed to really give people the information that they need about Mpox so that they can make informed decisions for their own health. And so we're going to talk a lot more about that in a moment. In addition, so much of this has been driven and supported by the very meaningful engagement we've had across communities. So given that the outbreak is really focused on LGBTQ folks, specifically those of color, we've really worked to make sure that that they have a place at the table and that what they say really helps us nuance and calibrate our response so that we're able to make sure that we approach equity as best we can, given the challenges often experienced, given the systemic issues that often get in our way. And we're going to talk about that in a moment. So where we are today, obviously lots more work to do. We have a new name. It's called Mpox. We have adequate amounts of vaccine to be able to vaccinate the populations that need to be vaccinated. We have access to the drugs that we think treat Mpox, as well as to studies that allow folks to access the drug and also help us learn how it works. And we have adequate testing in the United States so that we're able to make sure that folks are aware if they have Mpox or no. So our big message is that Mpox isn't over, but that we really need to keep calm and finish the job that's at hand. So that really makes me pull back into where are we now in terms of the epidemiology of Mpox in the United States. Damien, just a quick check. Are my slides moving okay?
Yes, we are in state of epidemiology.
Great, just double checking. Thank you. In terms of what we've seen so far, as of May 31st, 2023, there have been 30,450 cases and 42 deaths reported in the United States related to Mpox. On this map, the darker the state or jurisdiction, the higher the number of cases that are identified. Looking at the whole Mpox story, you can see that we have made a lot of progress. So the very top panel, this here shows the entire duration of the outbreak. And you can see that we had a peak sometime in August. And then since then, we have very few cases that are reported on a day-to-day basis. The panel below here actually then shows you a zoomed view of 2023. And you can see that we still have cases reported and on average, somewhere between 1 and 2 cases per day. Recently, there has been a cluster of cases reported in Chicago, over 30 cases, and many of those individuals, not quite half, were vaccinated against Mpox. Those individuals, it's really important to note, though they got Mpox, have had milder disease, which is really important. And we're going to talk more about that when we talk about the vaccine and getting summer ready. So in terms of the demographics of who's gotten Mpox, about 60% of people who are diagnosed with Mpox in the United States are Black or Latinx. The majority, 95%, are cisgender men. About 3% are cisgender women. Transgender men make about 0.2%. Transgender women about 0.9%. And folks with other gender identities make up 0.8%. You can see that the ages tend to be less than 45, but also there are folks who are younger and older who have been diagnosed with Mpox. So I want to start here with that as background to talk about how we prevent Mpox and what that whole toolkit looks like, as well as stepping back and looking at some data that tells us about where our risks are in the future for outbreaks of Mpox in the United States. So first, I'll start by sharing what's in the Mpox toolkit. So I'll start by saying that the Mpox toolkit actually lives within our sexual health toolkit. When you open it up and look inside, there are 3 main tools that we need to use to prevent Mpox. The hammer is vaccine. Get 2 doses of vaccine to make sure that you have the best protection against Mpox and its complications. So like I told you before, some people who get Mpox after vaccination have much milder disease. The second tool is testing. If you have a rash or symptoms, whether or not you've had Mpox before or have been vaccinated, it's important to get tested. And then lastly, knowledge is power. Know how Mpox is transmitted and where Mpox might be circulating, where you live, work, or play, so you can make informed decisions about your sex and social life. So let's talk more about vaccine. On May 18th, the anniversary of the beginning of the outbreak, CDC released 3 really important studies asking the question, how well does the vaccine work in preventing Mpox? That doesn't mean preventing the complications. It means actually preventing getting the infection. And so the studies are a little bit different. They have different populations. They ask different questions. The first study was able to look at the vaccine not in a deeper way, or shallow way, or mixed. Also, they asked the question, people with weakened immune systems, like some people living with HIV, how did the vaccine work? So the big message is that with the first dose, almost 75% protection, and the second dose, 86%. There was no difference in terms of the effectiveness of the vaccine based on how it was administered, and folks with weakened immune systems seemed to do about as well. The second study was much bigger, and it looked at medical records and asked the question, how do folks who are diagnosed with Mpox compare to other people who are living with HIV or on PrEP? And what they found was that the vaccine was about 35% effective in 1 dose and 66% effective in 2. Another study, only in New York, asked the question, how do people living with Mpox compare to people who are being diagnosed with syphilis or gonorrhea or chlamydia in terms of protection? And what they found was 1 dose, about 68%, 2 doses, about 88.5%, and overall 75.7%. So there's a lot of confusing numbers here. The most important thing is all of these numbers overlap and really have one message. If you have no doses of vaccine, you have 0 vaccine protection. If you have 1 dose of vaccine, you have some vaccine protection. If you have both doses of vaccine, you have the best vaccine protection. That's the main message. So there's a lot of numbers to think about, but somewhere in the neighborhood of about 70% protection if you get both doses of vaccine. A lot less with only 1 dose and nothing with 0. So who should consider getting vaccination? So folks who have more than 1 sex partner and or a history of sexually transmitted infections, if they are members of the community of gay, bisexual, other men who have sex with men, or gender diverse or transgender individuals, if they are participating in festivals or events that have sex associated and have sex at those events, they also ought to consider vaccination. People living with HIV who have any of those risk factors should be prioritized, and all of their sex partners also qualify for vaccine. What's important is it's not just about the past, it's also about the now and the future. So if folks have are planning or have had exposures that could increase their risk for Mpox, they should consider vaccination if they see themselves within these descriptions. So far in the US, we've given over 1.2 million doses of vaccine. This graph shows you first and second doses, and you can see that vaccination really does trail off. And it actually looks a lot like the case curve. So as the cases went down, people were less interested in vaccine. But what we need to see is that that curve at the end here picks up again, because we have not finished the job of protecting the US and us against Mpox. Let me tell you what I mean by that. CDC did some mathematical modeling. They did a study and they asked the question, how much vaccination do we have to do to be able to protect the community against Mpox? So what they found was the more immunity that there is in the community, the less likely it is that we're going to have any outbreaks at all. They also asked the question, is there a threshold? Is there a line, a percentage of people who have been vaccinated that if we are under, we're at risk for large outbreaks? And the answer is, if we vaccinated less than 30 to 35% of a community at risk, we're at risk for an outbreak that's as big as the belly of the beginning of this one, or potentially even bigger. So the question that you should ask then is, well, how are we actually doing? So in terms of first dose in the United States, 37% of people have been vaccinated. Remember, that provides some protection. In terms of fully vaccinated, that provides the best protection. Only 23% of individuals are vaccinated. That reminds us that we are at substantial risk for ongoing outbreaks of Mpox, and not only ongoing outbreaks, but ones that could potentially be as big or bigger than the one that we had when we had a lot of cases in 2022. Also important to look very carefully at what's going on with vaccination. CDC did a very interesting study that asked the question, how fairly are we giving out vaccine? They did a very interesting study, and what they said was, how many people were vaccinated for for each individual who had Mpox in a certain population? And they looked at this using race and ethnicity. So what they found was that for every single case of Mpox in a white person, 43 white people were vaccinated. Single case in a Latinx or Hispanic person, 17 were vaccinated. And for every case in a Black person, 9 were vaccinated. So when they showed me this graph, I said, this looks really familiar because it's identical to the PrEP to need ratio for HIV PrEP. And what you see is that the systemic racism that makes it hard for us to do HIV prevention is also the same factor at play that makes it difficult for us to make sure that this vaccine is being reached adequately. Sorry, I'm gonna leave the room. I've been kicked out of my room, which is my fault. Internet problem.
Are you still with us, Dimitri?
So thanks for getting me. So I'll just keep.
We can't hear you, Dimitri. Can you hear us?
Continue to get folks into the STOMP study. The STOMP study that the NIH opened, which is accessible by this phone number, is an opportunity for us to let people access drug if they need it, but also learn how the drug actually works in treating Mpox. I think that Damian also talked about the Mpox syndemic, and I wanted to talk about what that meant and sort of really the idea of a syndemic strategy for actually addressing Mpox. So just so we're all on the same page, syndemics are epidemics that interact with each other, and by that interaction, increase their adverse effects on the health of communities that face systematic, structural, and other inequities. So let me put that into a picture so you know what I'm talking about. So Mpox, the infection interacts with HIV and STIs, and also interacts with other factors like drug use and mental health. Something about Mpox and HIV make each other work.
Dimitri, we cannot hear you. Can you hear us?
Is it because it's in the same people?
What? Dimitri, can you hear us? I think your connection is a little bit unstable. Dimitri, can you hear us? Sorry, folks, for the technical difficulties. Can you hear us now, Dimitri? No. Dimitri, can you hear us? We can see your slides moving, but we cannot hear you.
The question, who are the people with the most severe Mpox that we know about in the US?
Dimitri, we cannot hear
57
you.
folks were reported to CDC who had very severe Mpox who were admitted to the hospital. What we found was that over 80 people living with quarters had T cells that were less than 50. That's not their viral load, those are their T cells. Only about 10% of them were living with were on HIV medicines, and like I showed you in the syndemic model, the social determinants of health made everything worse. Systemic racism was in play. Homelessness was in play. 70% of the people who were hospitalized were Black, and almost a quarter were homeless. And that really then played out in what we saw with some of the individuals who died of Mpox. So we learned of the 42, data has been published on 38. And what we found was that 87% of them were Black, almost all, over half of them lived in the South, most were cisgender men, and of the ones who had housing data, about half of them were experiencing homelessness. When compared to people who survived Mpox, people who passed away were about 3 times more likely to have HIV, about 10 times less likely to have received the Jynneos vaccine. So only one of them received the Jynneos vaccine. All had CD4 counts that were low, almost 96% of them less than 50. And the one person who had a CD4 count over 50 had a CD4 count less than 200. And like I said, almost none of them were taking medicines. Another study from Los Angeles asked the question, what do we know about Mpox in homeless people? And the surprising result was that 60% of the homeless people who were diagnosed with Mpox were living with HIV, and only half of them were virally suppressed. Many of them required hospitalization. So that's what a syndemic is about. Interacting infections that are then made worse by things like racism, sexism, homophobia, transphobia, and homelessness. So really critical that as we approach Mpox, we remember that Mpox prevention is HIV prevention, access to housing is Mpox and HIV prevention, and reaching people for Mpox vaccine is an opportunity to address both HIV and other STIs. Which leads me to, how do you get Pride ready? How do you put together a syndemic strategy so that you're able to enjoy the summer and make sure that you are ready to go? So I'll start again by reminding you about the whole Mpox toolkit. We'll start with a hammer. Remember, 2 doses of vaccine, make sure that you have the best protection against Mpox and its complications. Don't forget the wrench, that's getting tested. If you have a rash or symptoms, whether or not you have Mpox or have been vaccinated, you should get tested, and make sure you know about Mpox and what's going on in your community so that you can use that information to make informed decisions about how you have sex and how you socialize. But that toolkit is only a piece of the story. There's more to getting summer ready. If you're traveling, know before you go. Make sure you know if there are any preparations you need to make or special precautions you should take before you pack for your trip. I recommend 2 or 4 weeks in advance. Think about what you need to do before you go if you're going anywhere outside of the country or even in other areas in the country. Play sure. Get up to date on all your sexual health checklists, and that includes HIV testing, STI testing, HIV treatment if you're living with HIV, PrEP if you're not, vaccines, and other prevention. Best advice is visit your healthcare provider.
Dimitri, I'm sorry, can you hear us? I think we lost you. We lost your audio again.
use drugs or you use drugs yourself, make sure that you know how you can prevent overdose. And that can include naloxone and in some jurisdictions also fentanyl test strips. So these are often available from your local health department or pharmacy. All of this can be found in a great website that we produce called Get Healthy and Ready for Summer 2023. This is accessible on the cdc.gov website. There it includes all of the factors
I'm sorry. Sorry again for the technical difficulties, Dimitri. We cannot. We lost you. Okay, this is still okay.
Are you all there?
I'm sorry.
Can you hear me?
Yes, we can hear now.
Can you hear me?
Yes, we can hear now. Thank you so much, Dimitri. Hope that you can hear us better. You can there you have Dimitri's email. You can send any questions or concerns. Dimitri, if you can I ask you to please stop sharing screen, and then we can pass over to the community conversation. We can pass over to the community conversation with Joe and Alan. Um, Again, thank you so much, Dimitri. And I think a couple of highlights from what you were presenting is that first, Mpox is not over. Mpox is still here, and that people still have to get vaccinated. There is still work to be done around vaccination, and that some protection is better than no protection, especially now as we are approaching the summer and we are all getting into having fun, having sexy times, and enjoying ourselves during the summer and beyond. And also for me, it was really interesting what you were mentioning about the syndemics and the diagram that you were showing when one condition is present, how others get exacerbated. And I think it relates to, Mpox and also the work that we do in HIV and other STIs. But I think the highlight for me was also that we have been here before in terms of disparities, right? As Dimitri was comparing Mpox versus HIV, we have seen the same. We are seeing essentially the same disparities along the lines of sexual orientation and race. So I wanted to open up the conversation with Alan and Joe to please give your opening thoughts, and what do you think we can do to not to start, but to continue addressing these disparities?
Yeah, definitely. So first of all, I just want to say thank you so much to Dimitri. I think he synthesized a lot of information very clearly. And I really appreciated emphasizing the unfortunate parallels between those data charts, and really emphasizing, especially with gay men of color communities, for Hispanics and Black men, when we're looking at the data and we're talking about staying healthy, but then we're seeing data that shows even when people are getting access to medication, they're not getting virally suppressed, or that they don't have access to the prevention services at the same rates as their white peers. So I think that the data shows, that our challenges in wanting to address the Mpox epidemic is to look at the data where we're failing in other aspects of trying to target sexual health issues. And so STIs, mental health, and the stigma associated with all of that, all of those challenges we need to bring in, and that is more work that we need to do. But at the same time, that means that we could rely on our institutional knowledge and the work that we've already done in those communities, and bring that work into the space that we're doing here. So I do think that it is the right approach to this, and that does make it more daunting. But at the same time, then it means that we're not starting from scratch. We already know the work that lies ahead, and I'm glad that we're having this conversation.
I'm glad that we're having this conversation, but ultimately it's the kind of the same issue, different cast. And so that's disappointing, to be quite frank, to be very transparent, that the same communities continue to be disproportionately impacted by various diseases, epidemics, and viruses. And so I think it's an indictment of the system. It's an indictment of the approach. It's an indictment of our federal, state, and local governments for not continuing to center the people who are disproportionately impacted by all of these things. And so until we can get to the root cause of that, until we can start talking about systemic racism, medical racism in an accurate, and genuine way, a vulnerable way, we're going to continue to see these the same thing perpetuated in the next epidemic. And so I think there are people who are boots on the ground who are ready and have some ideas to do this, but there's a complete disconnect between the people who make the policy decisions and the people who actually can implement the ideas and things to resolve some of these issues.
I agree. I think even when we look at the way that people talk about the resources that are out there, it's like, oh, there are vaccines that you could take, but then how do you get access to those vaccines? And I remember last year, it really felt like secret information that was out there, and that you had to know the right people to get on the right list or have the right person text you. And then even once you knew who to call, you basically had to be like, I swear I'm really slutty, and like share a lot of personal information about your sex life. And then maybe even some people felt that they needed to lie in order to be able to get the vaccine. But then also, those structural barriers, who is best prepared to be able to take on those kind of administrative burdens in the middle of the day, right? People with more affluent jobs, people with higher education, people that are not wage workers, and can't have their phone with them when they're working, right? That these are people that could walk away from their desk, make a phone call, and schedule a doctor's appointment in the middle of the day. So I think even when they try to make appointments available in the evening, you're still forgetting, like these are people who oftentimes have stronger ties to their families and have stronger interpersonal relationships with people, where they can't necessarily get away in the middle of the day to go get a shot, okay, it's going to be in the evening at 7 p.m., but it's like, what are you doing in this random part of town at 7 p.m. at this time, and people are going to be wanting to know where you're at. And then even just, the scar from the shot, I think discourage people from wanting to get vaccinated. So I think that there's a lot of those structural issues that you're talking about over here, and they're exactly the same that we've been dealing with before. But I think how we have that conversation with each other, I think it's harder here because of that stigma.
And I think that as you were saying, you said we are not starting from zero, and I agree, right? We come from a long history of organizing from the basis, whether it is for HIV or LGBTQ advocacy, and I think one of the things that was different for me in this experience about monkeypox, and Dimitri, I hope that you are still us and that you can hear us. I think that that for me, I was part of the White House workshop for Mpox, and I think one of the learnings I think that for me, and for example O'Neill Institute, who did who published some research about community engagement, was that being able to reach out to the community, to update the policies and update the procedures, or in general how the how Mpox was being treated. And I think that was not only refreshing, but I think it was also really eye-opening in terms of the work that still needs to do and how we still need to build up from the work that we are currently doing with HIV. Because I think that where with Mpox, there are so many similarities, and yet we are seeing the same disparities. So yeah, that definitely says that that there's still work to do. So I wonder, Dimitri, if you can hear us, if you can share some of the what has been done differently in terms of reaching out to the community. I also know that there was some equity efforts from the White House. If you can mention a little bit about that.
Sure. Can you hear me, Damian?
Yes, we can hear you.
Okay. So I'm on a phone, so I can't see you all. So I'm sorry about that. So I'm not going to go on video anymore. But yeah. So thank you. I think that we really did a lot of work to make sure that we had folks at the table. And so at the White House, we worked closely with the Office of the Assistant Secretary of Health, Admiral Levine, and we put together a workshop that was really focused on giving us feedback in real time on the response, so that we could calibrate it better to increase equity. So a lot of efforts sort of happened at the beginning, but ultimately this group ended up being really important for so many reasons. It was mainly Black and Latino individuals, almost all from the LGBTQ experience, mainly gay, bisexual, other same gender loving men, as well as some transgender folks. And they really, we got feedback, but also had accountability, where after we learned sort of what we should do, we then sort of returned back and let them know about sort of what's changed. We're not done with that workshop group. In fact, we're going to be reconvening it probably in the next 2 weeks, because we have a couple of new things that are happening that we do need to share. But I'll give you some examples, I think, that are really important. So the community told us, and I think I heard Alan say, there were some issues in terms of the risk assessment. So having to go through a system where you said, I'm a man who has sex with men who has a lot of partners. We got a lot of feedback about that, and we're able to pull the risk assessment completely out, so that you don't have to sort of report what level of what kind of sex or level of sexual activity you have to be able to get the vaccine. We also, figured out ways that we could give the vaccine so you didn't always have to get it on your forearm. The group also gave us feedback that we had to accelerate our efforts with the WHO to really encourage them to change the name. So I think that all of those, I can point right back to the community and say that, we really got that feedback from folks with like lived experiences in communities that were affected by Mpox, so that we were able to really accelerate some of those changes. The other thing we did is, beyond increasing vaccine supply, which was in itself an equity intervention, since so much of the limits were based on the fact that we didn't have enough vaccine. We also worked to get vaccine closer to people at events. And so there were a lot of examples, about 23 that were smaller, and then some very large ones where thousands of vaccines were administered. And we actually saw, not surprisingly, that when you engage with events like Black Pride, the house and ballroom community, you actually are going to get vaccine closer to people, and that folks take you up on it. So I guess in a nutshell, that's like an overview of some of the work that happened, although I think there's a lot more that we could talk about.
Yeah, I agree. I think that was really, all of that is really important. I know here in San Diego, the work that I do with our HIV planning group, we decided to create a task force specifically for Mpox, because we did see that taking a synergistic approach to tackling these issues would make sense because of the overlapping populations that were most at risk for this. And I know when we did that, we were able to very quickly be able to bring in a lot of people who were already doing a lot of work in the county around HIV, STI prevention, and plug them into this work, and then be able to quickly move around some of our contracts for our outreach efforts for people who were already, trusted voices in the community to then take on that message and share that more specifically in their communities, whether it was like in the South Bay, which is predominantly Latino, or in the North County region. And so targeting those messages, and then knowing that we could funnel that through our task force and the work that we're already doing on HIV and speaking with community engagement members, I think was really important to making sure that a more diverse group of people were having access to the information. And I think now that we're coming back to it this summer, having those conversations with people about needing to get vaccinated, I think is easier, because even the people that didn't get vaccinated last year are at least more aware of it this year. And so bridging that conversation, it seems to be a lot easier this time around.
I think at times we have two very different experiences. And so I'm in Texas, which is kind of lumped with the South, or it's the South, but and so the availability and access, like people say, like, yes, we went to these events, but okay, if you went to a Pride event, were you at the actual Pride festival, or were you like 10 blocks down the street, you know? And so we have access, you can get the vaccine, but did you set up a follow-up appointment? Like, these are real experiences that people are going through on the ground, where people up top say, like, yes, we did this. Yes, we can report we went to all these events, but did you really go to the event? Did you create another barrier for people to even access that? And that's the truth. And so I think I get frustrated at times, and maybe I don't want to speak out of turn, but and call out any organizations, but it's really frustrating for people to be on these calls and to be in meetings and say, like, yes, we did all of these things, but in reality, it was too hard for people to even access it. Like, I can't believe that we had, in one event, 200 people going to get Mpox vaccinations, but then there was no follow-up appointments. So these are the real experiences that people go through, and it's frustrating when you go through that experience to where, yeah, I got the first shot, but now I have to take time out of my schedule to call all of these places to see if there's even vaccine availability. And now it's like the Avatar, when the world needed her most, she vanished. We don't know anything about this. There's no campaign about this. There's no connection to the community. It's Pride. We haven't heard anything about Mpox. And so I think, like, yes, we can have these conversations, but until we actually follow through with the implementation, it's null and void. And so the communities who are already disproportionately impacted by HIV will continue to be disproportionately impacted by Mpox, because we haven't learned the lessons of actually how to engage with community in an organic way, in an honest way, and actually be there for the community.
Right. And so I think what you're talking to goes to like sustainability, right? So not just showing up once and giving something, because that goes to that like white savior kind of complex of like giving instead of like building up and having resiliency there. I really like your point about like, if you are at a Pride event, are you really there at the community, especially if you have to pay money to get into the festival space where this community space is happening? So like 100% that right there, I think is really difficult. And I hear you talking about, us having different experiences. And I think part of that might go to a community's sense of ownership of being able to take on something, So I think for here in San Diego, in California, we are more liberal over here. We have a much more representation in our elected officials and the LGBT. We're very lucky in that regard. And so I feel like when we were like, this is an issue, when we want to make sure that we have a community voice in it, we already had queer people, serving in those leadership positions, both in elected positions and appointed positions, who have been doing this work. And so we were able to have those conversations and very quickly create our own task force within, a government institution to be able to do that work. And I think in places where that sort of infrastructure doesn't already exist, it highlights those disparities even more. And then I could even say, for our end here, right, the disparities that have existed in the past in terms of our ability to reach out to like non-English speaking and Black populations are paralleled in our lack of vaccination rates in those communities as well for Mpox. So it's the same struggle again, it's just a new iteration of it.
No, and I agree about, I think that the conversation kind of relates and summarizes to that the message is as important, the messenger is as important as the message, right?
Yes.
That we have to see ourselves represented in, when a campaign is put out there, those that are reaching out to us, those that are reaching, encouraging people to get vaccinated. And also, I think you both bring an important issue about the intersectionality with Mpox disparities, and being tired and having to work, for many of us, or for many of Latino folks, for example, that need to have at least two jobs to be able to survive, or people that have less access to education or less access to housing. Getting vaccinated is not necessarily a priority for them. And how, I know this is more at the systemic level, but I think it also speaks about where we are as a, as a society in that sense, and that if we don't address those kind of disparities, we are not necessarily going to see a huge change in numbers, or in these disparities for Latino and Black MSM.
Hey, Damian, do you mind if I actually add a quick thing really quickly?
Yes, of course.
So I heard, and so thank you all for it's really great, important feedback. I just wanted to comment on something that Alan said, which I think I didn't actually mention in the presentation because I was focusing more on advice, but in terms of how to sort of stay summer ready. But I think one of the things that Alan talked about was the fact that he was working through the Ryan White and Prevention Planning Council to be able to sort of work with resources. And I think one of the things that I didn't talk about is that one of the sustainable components of the Mpox response that's so important is that we actually created historical flexibilities in Ryan White, in CDC, HIV, and STI funding, in SAMHSA for substance user health as well as mental health, and then also HUD in housing for HOPWA, as well as homeless resources that are agnostic to HIV status. So all of those are one of the reasons that you were actually able to work in the Planning Council to be able to actually do Mpox work, because those funding flexibilities that we created were really designed to sort of make the point that this is a syndemic situation. These are interacting infections, and that we really need to support them using all of the HIV, STI, mental health, and housing infrastructure. So that sort of experience that you had on the ground in San Diego, I think, was also supported by some of the work that happened sort of with our interaction with the community on the national level that said we need to create those flexibilities. Those flexibilities haven't gone anywhere. So all of the sort of Ryan White resources and CDC, HIV, STD resources, as well as SAMHSA mental health resources and housing resources, are all still available to be able to address the Mpox endemic. So I think it's really important to hear that. In terms of sustainability, I think, Joe, you're right. I think that it's really been challenging to sort of make sure that folks remember the drumbeat of making sure that we get vaccine to people. And so I think that unfortunately the cases that we saw in Chicago is actually stimulating attention again, because we also have some sort of issues with demand. So I think that the good news is that I think we're really trying to get back to those places, and also make sure that where folks are seeking care, like sexual health clinics, like Ryan White clinics, all of those are actually tuned in really closely to making sure that we provide vaccines in both traditional and non-traditional places. Just wanted to make sure I didn't talk about those things, and that's really like the core piece, which is like all those pieces. The sustainability is we put Mpox as part of their story. So that's going to be how we're going to be able to move it forward as we go forward and really help address some of the important issues you all brought up. I mean, I'll get back to you. Sorry. I hope you can hear me still.
Yes, we can hear you perfectly. And thank you for that background and that additional information. And I know that we are just a little bit over time, but I wanted to make sure that we have time for questions from the audience. And thank you for those who have stayed with us. Chip, do we have questions from the audience?
We do. And you can hear me just fine?
Yes, we can. Yeah.
Okay. So I have a question for Dimitri. What is being done at the Fed level about the bicillin shortage and exorbitant pricing? This makes it really hard for community providers to treat and prevent syphilis in their communities.
So great. So unfortunately, I'm not touching the bicillin piece of the story, but I know I know that there are discussions happening over in the Domestic Policy Council where that's happening. So I'm sorry that I don't have sort of more definitive information about that because it's not really what I'm working on right now at the White House. But I know that that there are folks in the White House who are working with HHS and others to sort of really deal with the issue. So I think you're 100% right that the shortage is significant and the pricing is definitely a barrier for us to control syphilis. But unfortunately, I may not be the right person to ask that question to.
Okay. Next question. Is there any non-anecdotal information regarding how long vaccine protection lasts? What is the likelihood smaller intradermal dose imparts similar efficacy to the original dosing recommendations? If not, are there efforts to investigate the long-term efficacy in the coming year?
So not even in the coming years, it's all happening now. So I'll first start to say that the vaccine effectiveness data that I presented actually does include a study that compares the intradermal to the subcutaneous, and there's no difference in its effectiveness based on that study. So we're still looking at the other studies that are accruing data, and as we learn more, we will share more. But also what we're seeing in Chicago, as an example, there's no pattern. So it doesn't seem as if there's really anything that maps toward the intradermal dosing or the subcutaneous dosing working less or better. So I think that they're based on the studies equivalent. There are 3 studies happening, one internationally and one domestically, to answer the question of how long does the protection for of the vaccine last. So there's one that's happening in the Democratic Republic of Congo that's been going on for over 3 years. They are just looking into their 2-year booster timeframe to sort of identify how the booster worked and if there's sort of what the indications are there. There are 2 studies happening in the United States, one in the District of Columbia and one in Los Angeles, which are following people prospectively who have been vaccinated with the Jynneos vaccine, asking the same question, looking at sort of levels of immunity in their blood. And so those studies are ongoing, and we're really working to accelerate the data as we can get it in real time. Obviously, this is unfolding in real time. It's not something that we really have in retrospect. So as we accrue data, one of the important pieces of feedback that we've gotten from our equity sort of workshop is that we need to be transparent with data as quickly as possible, which is why as we learn it, we release it. And so that's what we're doing. And so those 3 studies are all in play, and as we learn more about duration of protection, we will share it. Right now, there is no recommendation for an additional dose for people who were vaccinated during this outbreak. And so as we learn more, that could change, but at the moment, the data are not supporting making a change at this time. Thank you.
Next question. Dimitri, you noted the medication that may treat Mpox in your presentation. Can you elaborate on what you meant by that? How does treatment for Mpox work?
So there's no drug that's approved to treat Mpox. So the drug that is provided right now is called tecovirimat, or TPOXX. That drug was only studied in animals and was approved for use against smallpox. So it's actually not approved for use in Mpox. It is available through an expanded access program at the CDC, but then more importantly now is also available through a study called the STOMP trial. The STOMP trial is really important because learning if the drug actually works against Mpox means that we could potentially get the drug onto the market so that people can get it in a more routine fashion as opposed to through public health or others as it's been going through this expanded access IND. So the drug is safe. We have about 7,000 people who have been treated with it. We don't know if it is effective, and that's why really getting folks onto the STOMP study ends up being so critical. We're recruiting the study both in the United States as well as internationally. And so as we get more information and get more folks on the study, I hope that one day we'll be able to look at tecovirimat or TPOXX and say that it is a proven treatment for Mpox. So we've made a lot of different pathways for people to be able to access this investigational drug. But again, we don't know if it works yet.
Dimitri, would you be able to elaborate on the use of TPOXX in conjunction with gabapentin for pain management?
So pain management is proven treatment for Mpox. Let's start with that. So I think that there's actually like a great letter that CDC released last fall that talks about the importance of pain management. And I think though the evidence for gabapentin tends to be anecdotal, it's among the drugs that are included. So really the importance of actually sort of treating the pain of Mpox is really critical. And one of the things that we can see with Mpox is that some people may not have a lot of external lesions, but they could have a lot of rectal or oral lesions that lead to some significant pain. And so we've given medical providers the first and most important advice, which is that if you have someone who has pain, who has Mpox, treat it. And as you said, gabapentin or Neurontin is one of the drugs that is sort of anecdotally demonstrated, like that folks have said is helping, and is also included in that CDC letter. So yeah, I think it's really important. The other part, just to be able to throw in there, is that vaccination also prevents a lot of the more severe complications of Mpox if you get Mpox after vaccine. So again, it's anecdotal. We're still learning more, but many of the people who have gotten Mpox infections after vaccination aren't having the same level of pain. And many of them actually, most of them, at least in the initial reports from Chicago, do not have any of the rectal symptoms. So we're going to learn more about that. That investigation's ongoing, but definitely pain control, that is a demonstrated way to treat Mpox, as we learn how the investigational drug works to actually reduce the duration of illness.
Thank you.
Thanks, Alan.
Chip,
Okay,
can we have one more before we close?
Sure. What are some suggestions for reaching those who are most in need for vaccine when you may not know where to go to reach them?
That's for me. Is it for me? I think that's for me.
It could be, or it could be for anyone else. Yeah.
Let everyone else go first, and I'll finish it up. How's that? I think that they're the experts, so I'll do my part at the end. How's that?
So I would start with culturally relevant communications, and so that's going to be different in every community. And I think a lot of times people think of a Black community as a monolith, or as a Spanish-speaking community as a monolith. And I can tell you that the Spanish that we speak here in San Diego is very different from the Spanish that they speak over there in Texas. And so knowing that and making sure that you're working with people of those communities to make sure that the communication is culturally relevant and timely for the people that you're speaking to, right? And so knowing your audiences in terms of people of color, but also working with trans and gender non-binary individuals, because I think a lot of this messaging has been really targeted for gay men and men who have sex with men, and not as much as for non-binary individuals who might have sex with men, or pansexual individuals who have sex with people of various genders who have sex with people who have sex with men. And so I think those more like gender expansive languages, I think is something that I've seen missing in certain communities and spaces. And then also not just targeting sexual health clinics or STI clinics or the county, like the free clinics, but a lot of, especially like in Latino communities, people go to the same doctor their whole life and only stop seeing their pediatrician when they're like 25 or 26 and get kicked off their parents' plan, and so meeting people and giving information to their primary care providers, regardless of where they are at, so that they can connect that information, even if they're not the ones providing the vaccine there, that they're connecting people to that information as just standard health, instead of treating it as like something different that needs to be stigmatized, I think is really important.
I think ultimately it varies community by community, as Alan was saying. And so you have to have a really good pulse on your community. And I'm not saying like the health departments and public health departments and stuff like that, the sexual health clinics. I'm saying the girl that you call to know where to go at 11 o'clock where you can get free drinks. You need to know those people, because they're going to be able to amplify your message in the community. You have to know the people that you call to be like, you call to get, where can I go and get PrEP? Those folks who are amplifiers, you have to know those girls, because that's important in getting your message out. And I think also we are stuck in this when I think when we do stuff like this, we automatically go to the health departments, which is great. I think we have to, work in conjunction, but they're stuck and sometimes in a 9 to 5 mindset when a lot of stuff happens after that. At 11 o'clock at night, at 1 a.m. At drag shows or bars and stuff like that, or on the weekends when someone who's a pillar in the community hosts an annual fish fry and everybody in the community is going to be there, you need to be there. Maybe not, telling people or giving the vaccine, but telling people, signing people up for access to it. And so these are some easy things that you can do, but you have to really know the pulse of your community and who your community champions are that will amplify your message, that you can just call and be like, hey, we're trying to get people awareness. We're trying to let people know about this access to this care.
I love that, Joe. It's like actual community, not using an institution as a proxy for the people that you're trying to reach.
Yes.
All right,
Dimitri, any
let's
final thoughts?
Okay, I can keep going if y'all want me to.
No, I'll just say, like, y'all are the experts, and so we're grateful for that expert advice. And I think we're really motivating a very new sort of effort in terms of looking at how, so as we approach sort of summer events, I think one of the things that we've been told by our workshop, and I think for those on the workshop, it's coming soon. Round 9, I think, of the workshop is coming in. And one of the things that we were told is that we have to do better with sort of Black prides across the country and do better with the house and ballroom community. So that's our next phase, because we know that the folks in those organizations, and organizations taken loosely, like folks who are in that universe, are really trusted messengers. And that I think, exactly as Joe said, it's not always about having vaccine on the ground. It's about having voices on the ground that people listen to, and then the right street signs that point you where you need to go, when you feel that it's the right place to do and the right time to do it. So so thank you for your expert advice. I think that we're going to be on target, and I promise we're going to take a lot of this back to be able to develop it even further, because it's such useful advice. And I think the more that we're trying to sort of really meet people in ways that make the most sense for them, as opposed to how we think that they want to be met, the better that we're going to do. And so you all are important links to that. So, like, the messaging that you do, your experience with your own community, and really pointing them to resources that you trust and like, I think are great. So I'm going to just say I don't have a lot much more to add, except for thank you for your expert opinion.
And can I say one more thing? We kind of shy away from it, I feel, in like these very formal discussions, but we have to start acknowledging that we have to be sex positive, and that there are play parties all across the country.
Oh, yeah.
Especially when it comes to communities of color. And so if we're not engaging with people who host these events, who throw these events, then we're already doing disservice to the community, because we're not acknowledging the activities that happen in the event, in the community. So I think, like, we have to talk about sex parties. We have to talk about play parties. We have to equip the people who throw these events with the knowledge of the resources that we have to be able to work in conjunction with some fun, innovative ways to get people access to what they need.
I'm so glad you said that, Joe, because I think, to me, it's like painting with all of the colors that you have available to you. And I think when you start putting things in silos, like, oh, this is an Mpox issue for the queers over here, instead of like putting it into, the whole spectrum of sexual health, which includes agency, consent, and risk assessment, then people don't take it as seriously, And so for me, I think one of the things that I'd really like to see is Mpox information included with, doxy-PEP information. Like, I've been seeing a lot of posts about like disco dosing PrEP, and for people that don't have regular access to PrEP, why isn't there an infographic that has all of this information in one place for it? Because it all deals with sexual health. It all deals with tools and resources that are available for people, so that they can make their own decisions about what risk that they want to take as they're engaging, in sexy time with other people consensually. And I think it's harder when we try to treat each of these things as its own separate thing, and then pretend that things aren't happening. Like, gays are having sex. Let's talk about that, and like, not stigmatize it. And then once we do that, then we can talk about all of these tools openly, because they're all available to us, and we should share that information.
Dimitri, I don't know if you have any final comments on that before we close out.
Sure. So I'll say, my history in life is coming from sex clubs into public health and bringing public health into those events. And so I think it's we've been working really hard, I think, in terms of the messaging. So you can take a look at all of the Mpox messaging, where CDC in their messaging now actually says the word sex club and bathhouse and all of the things to be able to sort of really motivate some efforts. So I think we're with you. And I think that's sort of, when we were talking syndemics, that's kind of what I'm talking about. So if you look at sort of the website that we came up with that focuses on the community, it's not about Mpox. Mpox is like the 100th thing on the list, but it sort of talks about HIV, STI prevention. It talks about overdose, which I think is actually good sexual health, as well as like other resources. So I think we're on the same page, and I think it's really important feedback as we sort of further nuance this response in the context of a larger HIV, STI, drug user, mental health, and housing response. So it's really good advice. Thank you.
Awesome. Thank you everyone for your comments, your time, your wisdom, sharing your experiences. I really appreciate it. Thank you, Alan, Joe, Dimitri. And thank you for the folks in the audience for your questions and for being patient with us. I hope we see you on our next webinar, part of the Gay Men of Color Fellowship. And that's it from us. Have a great rest of your day. Thank you, everyone.
Thank you, Damian. Thank you, Joe, Dimitri.
Bye.
Thank you, everybody. Sorry about my technical difficulties. I hope it was okay. I have no idea if you could hear a word I said.
No
I'll talk to you.
worries. Thank you. Bye.
Thanks. Bye-bye.